Dr. Narayanan, State President of IAP, Dr. Anandakeshavan, National Vice President, Dr. Bala, Secretary IAP, Guest of the Day, Speaker of the Day, Dr. Raju KHUBCHANDANI, Chair of the session, Dr. Sudha Madam, respected teachers, colleagues, and friends. Today is the 5th talk of Beyond Horizon Meet the Doyens series. My duty is to welcome you all. Today's speaker is Dr. Raju KHUBCHANDANI. We know he needs no introduction to this audience, not only to this audience, to any audience. Because in the beginning, one of the participants in the meeting, Dr. Paranjit, also already gave an introduction. So to save the time, on behalf of IAP Kerala and on behalf of IAP Kozhikode, a warm welcome to you, sir, KHUBCHANDANI sir. Then I welcome Chair of the session, Dr. Sudha Madam. Madam is a senior consultant in MIMS Hospital and previous HOD and previous Associate Professor of Government Medical College, Calicut. Madam is very active in academic as well as the extracurricular activities. A warm welcome to you, Madam. I welcome State President Dr. Narayanan, Dr. National Vice President Anandakeshavan, Secretary Bala, past Honorary Secretary General of IAP, Dr. Ramesh, all my respected teachers and my friends to this Zoom meeting. With these words, our State President, to save time, Dr. Narayanan already asked me to convey his regards to this webinar as well as to convey his regards to KHUBCHANDANI sir. To save time, he's not speaking. I invite Dr. Anandakeshavan for inaugural remarks.
Very good evening, respected Chairperson Dr. Ashraf. The most wanted speaker in Kerala, one of the most, Dr. Raju KHUBCHANDANI sir, and State President Dr. Narayanan, Dr. Ramesh, and other dear friends. It's very happy to see Raju sir again, because we missed him here in Kannur also. Kannur also we had, at that time there was some lockdown at that time, but at that time also he heard his talk on the, not webinar, but we are seeing his, because he could not attend that meeting due to some physical problems. So I think that was the last talk we have heard. Raju sir, very happy to see you again. And without wasting any time, I wish the Calicut branch all the best and also congratulate them for arranging this wonderful academic visit. Over to Ashraf.
Thank you, Dr. Anandakeshavan. Dr. Ramesh is the coordinator of the scientific committee of this webinar. Over to you, Dr. Ramesh, for your words.
Respected President State Dr. Narayanan, President of Kozhikode, our Chief Guest today, our Vice President's house son Dr. Anandakeshavan, President Kozhikode Dr. Ashraf, our faculty for the day and our eminent speaker Dr. Raju KHUBCHANDANI sir, Chairperson of the day Dr. Sudha ma'am, Sashisaran sir, all seniors and my friends from outside Kerala and from Kerala and DS. It's a great time for IAP Calicut and ISC Kerala when they are racing on to the 5th on the series of the Doyens of Pediatrics. And it's gone quite well and been quite impressive show over the last 2 or 3 weeks. And we have got, for the day, we have got eminent faculty here, Dr. Raju KHUBCHANDANI. We had a very good introduction from Dr. Paranjit Singh regards the eminence he enjoys in Indian as well as international arena. And rheumatology, sir, is the last word. So we will hope to have an exciting session here today. And we have as chair, Dr. Sudha ma'am. I remember her so much when I was a state secretary. Ma'am was the president of IAP Kozhikode, and I got a lot of inspiration from ma'am to work for IAP, and the passion for IAP was built up in those days only. So I really owed a lot to ma'am and Dr. Suresh in Kozhikode at that time, and Dr. Vijay Kumar and Dr. Vijay Krishna and all the team. And respects to all the seniors in IAP Kozhikode and IAP Kerala and the participants, all seniors here, and let's get going for the great show ahead. Jai.
Thank you, Dr. Ramesh. With this, we are moving to the scientific session. Today's topic is auto-inflammatory disorders, and today's speaker is Dr. Raju KHUBCHANDANI, an excellent speaker, and his clinical discussion is simply superb. With this, I invite Dr. Sudha Madam to chair the session.
Good evening, everybody. Am I audible?
Yes, ma'am.
Yeah. So today we have a great speaker in the field of pediatric rheumatology. So this is the 5th webinar. We are halfway through the webinar series, and the topic is acute auto-inflammatory disorders. This is a diagnostic enigma not only for pediatricians, dermatologists, and sometimes also rheumatologists. So I think it is time we started learning this topic, and to untrap this trap, a double meaning intended, we have a great personality, a speaker par excellence, a doyen in the field of pediatric rheumatology. I just want to pick on your memory, sir. We met at the first ever pediatric rheumatology conference in Calicut 2005. So I will not be taking much of your time, but I would definitely like to give you a brief about he works as a consultant at the SRCC Children's Hospital and the head of rheumatology. He's a visiting consultant at Jaslok Hospital. And to his feather, he has foreign involvement as a faculty in Chicago Rabadi Children's Hospital and Great Ormond Street also. He has co-authored many books. So friends, I will not take much of your time. As Paramjit said, this legendary, this iconic speaker, friends, may I hand over the screen sharing to Dr. Raju KHUBCHANDANI. Over to you, sir.
Dr. Sudha, Dr. Paramjit, Dr. Ramesh Kumar, Dr. Ashraf, Dr. Ananda Kesavan, Dr. Narayanan, and so many of my friends who I see on the screen today, and I am really overwhelmed. There are only two thoughts which run in my mind as I start my talk today. The first thought is that amongst all these warm words that were spoken about me, there is one which is the most precious to me, one thought, that in the last 10 possible years, there is not one single state pedicon in Kerala where I have not been invited. And this to me is my most sacred thought, and that binds me with the audience today. And therefore, when I got a phone call inviting me for this, I had absolutely no differential diagnosis. I straight away said, yes, I think this is a brilliant opportunity. And I don't know whether I had a black tongue or what. Sorry, last I could not come because the flight bringing me back to Bombay was a 2 a.m. flight. And therefore, I would lose 3 days of work. And I did this talk on Zoom, exactly a very platform which I didn't realize we are going to live like for the rest of the 20 days. So let me come to the subject of this discussion. Just a moment to share a slide and then start. I hope everybody can see the slides well. And I would request Dr. Sudha or Dr. Ramesh to just say to me my voice is coming through okay. Kindly unmute yourself, Dr. Sudha, Dr. Ramesh. Please tell me that you can hear me well and you can see the slide well before I proceed. Can you hear me well?
There is some audio issue, sir.
Can you hear me well, Dr. Ramesh? Dr. Sudha?
Now it is clear, sir.
Lovely. Okay, and my slides are visible to you?
Yes, sir. Slides are visible.
Excellent. So today what I'm going to talk upon is an entirely new breed of rheumatological disorders which have made a presence very, very distinctly felt across the world only in the last 2 decades. Let me say to you that my mind goes back to approximately 20 years ago when we used to talk about Kawasaki disease. The earliest cases of Kawasaki were described by actually one of your seniors over there, Professor Noel Narayan. And I wonder whether he's in the audience today, but Lalita Kailas would remember we had met and collaborated and started on seeing Kawasaki in our country. Today, Kawasaki is a common everybody meets. The issue is that there are sometimes situations where the eye does not see what the mind does not know. And I strongly believe that this group of disorders we are going to discuss today exactly falls in that category. And it is just a matter of our looking more.
Sorry to interrupt, sir.
Yes.
Again, there is some audio issue, sir.
From my side, there is complete silence. My net is working perfectly.
Now it is clear, sir.
Yeah. So basically, a lot of what I am going to speak is the work that I have done and seen at this new children's hospital in Mumbai. And the people whose names appear are my colleagues in the hospital, my juniors, my fellows, etc. And these are the people with whom I have needed to collaborate overseas to get more knowledge of this very fascinating group of diseases. So the first important fact is, what are autoinflammatory diseases? So to understand, we have 2 types of immune system in our body. You have the adaptive immunity, which gives rise to antibody production. And then you have the innate immunity, which is the primary immunity, which is sort of governed by the macrophages and is our first line of defense to any microbe which invades us. So disorders of adaptive immunity are called autoimmune disorders, while disorders of innate immunity are called autoinflammatory disorders. Now, in these autoinflammatory disorders, you may look at it as 2 groups. One are the hereditary disorders, and the other are the non-hereditary disorders. So, for example, systemic GI, Behçet's disease, PFA, and chronic non-bacterial osteitis are classic examples of non-hereditary autoinflammatory disorders. While the subject of my talk primarily today is going to be the hereditary autoinflammatory disorders. Now look at how this story has unfolded. In the year 2006, there were only 4 diseases in this category which were really very, very well known. Familial Mediterranean fever, TRAPS, and now you know why Dr. Sudha used the word TRAP. This was human diagnosis factor receptor associated periodic fever, Sinca syndrome, and hyper IgD syndrome. Uniquely, one case of hyper IgD was reported from Kerala, and the author postulated that perhaps this was because the early settlers from the Dutch countries first touched the port of Vasco da Gama over there. And that is how the gene got imported to India. Now, what happened was that in the year 2000, to sequence all the genes in the human genome would cost $3.7 billion. Look what happened. In 2006, the cost went down to $10 million. In 2012, it went down to $5,000. In 2017 to $1,000. And today in India, one could perhaps have this story done for about $300 to $350 if you have to sequence the whole exome. I am not talking about the whole genome. Now, with this progressive reduction in cost, what happened was that there were several more opportunities to study patients who came with a phenotype of hereditary, what used to be called periodic fevers and are now called autoinflammatory diseases. But still, what was our problem? Rheumatology always flies below the radar. Therefore, while there were several panels available for neurologic testing for various other disease processes, but rheumatology panels were relatively restricted. So what happened in my own personal experience was that over a period of at least 7 to 8 years, I gathered 38 undiagnosed cases, and these were a major challenge. I knew that they were having some hereditary autoinflammatory disease, but which one it was, I was not able to tell, because till this period, I was entirely dependent upon foreign collaboration, sending blood samples overseas, requesting them, begging them to do the test, and waiting for years for the reports to arrive. So effectively, the time to diagnosis went up. It went up to as much as 12 or 13 years after the patient had first seen me. After I even would perhaps make a diagnosis, the awareness of autoinflammatory diseases was so poor that the moment I rang up the primary pediatrician to tell him, look, I have diagnosed your case as a case of Majid syndrome, he would wonder what I am talking to him. Then there were logistic and financial challenges of getting testing done. And besides that, when we would get the testing done, there would be some novel mutations in our country, which the international databases would not be very clear to tell us whether these were indeed pathogenic or not. Now, there are two global databases, and if you see the intersection of these two global databases, you find that these are all the genes which are today recognized as causative for autoinflammatory diseases. This paper was published in 2018, as you can see on the right. And there are several mechanisms in that inflammatory pathway whereby various autoinflammatory diseases occur, but we are all clinical practitioners. I will just tell you that these are the various pathways, but leave it to the pundits of basic science to follow. But what is very important is that there are several modes of inheritance, including de novo mutations and even somatic mutations, whereby these autoinflammatory diseases may manifest. The most unique feature, and one of my very senior mentors taught me, was that very often genetics holds the clue to acquired diseases. In what way? That today you have an adult acquired disease like sarcoidosis, and you have a monogenic genetic component in the form of Blau syndrome, which is the hereditary form of sarcoidosis. And as you can see on this slide, polyarthritis nodosa, which is a vasculitic illness, a medium vessel vasculitis, has a monogenic corresponding component called DADA2. Lupus has several monogenic components, hereditary complement deficiency being by far the commonest, and a few other examples that I have listed. But why this is important to know is that the monogenic component helps you to identify exactly where the block in the pathway is occurring, and therefore provides a very good experimental model to research treatments for these kind of acquired diseases going forward. So just to give you the various examples of the various modes of inheritance over here, and to tell you that in August 2019, Dr. Amita Agarwal, who is a big name in pediatric rheumatology and adult rheumatology in the country, she did a search through her sort of reaching out to various people, and found that totally there were about 250 odd cases that were reported all through the country, 248 as you can see on the slide. But mutation positive cases were 135. The bulk of the remaining difference were patients with CRMO, which is now called chronic non-bacterial osteitis, which is not called a hereditary form of autoinflammatory disease. So the number was just a meager 135. What did we do in this process? We identified those children and what are the bases. And this is a very, very crucial slide for all practicing pediatricians. Consanguinity, early onset of disease, family history going vertically, suggesting autosomal dominant, some peculiar inflammatory disorder which has not been identified. Very classic phenotype sometimes, and recurrent inexplicable features of inflammation, very classically involving skin, joints, and often other systems also. These were the features which you must remember and then suspect a hereditary autoinflammatory disease. This is a very key, crucial message I want to give through this slide. And what we did, we tested all these patients who were waiting with all these genes. It was unique. The patients did not pay too much money. They contributed only 25% of the funds. The remaining money we raised through crowdfunding, through friends and relatives of ours. And we were able to clearly pick up 11 out of 38 patients whom we finally tested having clearly pathogenic mutations. The remaining 27 are currently being worked up because some of them have come back with variants of uncertain significance, and some of them have come back with certain problems that we don't yet understand. And what we found was that our yield of 11 out of 38 was very, very comparable to various other studies which have been done on a similar basis. And what we were able to find, please note that these were all the diseases that we were able to identify effectively in our cohort. Prior to this study, we already had about 28 or 29 patients identified through foreign collaboration and, as I said, begging hands, begging feet, and getting testing done over several years. Straight away, that number in 6 months went up to 40. And if you see all these names, it is important to note that these diseases do exist in India. And clearly, please note that in places like Andhra and Telangana, the consanguinity rates are as high as 39%. And India has the second largest Muslim population in the world, where consanguinity is quite common. And therefore, we have to be very clear that we are only seeing the tip of the iceberg. And the remaining 27 are being currently worked up in Washington, D.C., where my fellow has gone to train specially in this branch only. With this sort of a background, let me take you through some of these fascinating cases, because I always believe that these cases are those which will ignite a fire in your mind and immediately make you remember and say, oh, 1 year ago I saw a child like this, and must be that he is having the same problem, and you will go back and call that patient. Now look at this boy from 2006 to 2011. He is having fever, intermittent abdominal pain, myositis, organomegaly. He has received various diagnoses, including systemic GI. He received lots of steroids, gets an osteoporotic fracture. He had mouth sores, scleritis, arthralgia, etc. And eventually, in 2011, I am not able to label him as anything at all. And I say that this child has possibly TRAPS, because his phenotype is closest to TRAPS. I do his mutation for whatever autoinflammatory diseases are known till then. He is negative for those. And I finally decide to put him on etanercept. And this is the same advice he gets when he goes to Boston Children's Hospital. Parents are very well off, and they say that, look, we don't know what this disease is. Please start him on etanercept. He agrees. He goes on to etanercept, which is a TNF blocker, and has a miraculous improvement. Up to 2019, he continues to keep well. In the meantime, I published this paper in Indian Pediatrics as a case of probable TRAPS-like illness who has responded well to treatment. Now, in 2011, I have sent this sample to NIH in Washington, D.C. when I meet the collaborator of mine over there. In 2019, this boy finishes his BSc in finance. He applies for a job, and in his pre-employment medical check is found to have a blood pressure of 180/120. but he has no symptoms. The same lady who collaborated with me visits Bombay, comes to my center for a talk, and I remind her about this case, and I call the parents there with the child. He is no longer a child, as you can see, because Dr. Ivana is very tickled or very perplexed by this case. She quickly runs back, digs out her files, and fast tracks that sample, which is still waiting in the queue in America. I, in the meantime, proceed with an MR angio, and as you can see, the renal vessel is significantly narrowed. There is a renal artery stenosis. The day I get the MR angio report, Ivona sends me an email to say that this child is homozygous for a DADA2 mutation. Now, what is DADA2? Deficiency of adenosine deaminase 2. You know that DADA of another type can cause immunodeficiency. This is DADA2. And DADA2 mutations can cause a vasculitic type illness, which basically is a medium vessel vasculitis. The key message I want you to take away today is that if you ever diagnose a patient with polyarthritis nodosa, 5% of these patients will have DADA2 mutation causing polyarthritis nodosa. The treatment, prognosis, genetic counseling changes radically. And therefore, today it is considered mandatory in every patient diagnosed with polyarthritis nodosa to test him for DADA2 mutation. But listen to the story. Why did I show you this case? For this very reason that I was in 2019, where I don't wish any of you to be. When I was seeing this child from 2006 to 2011, DADA2 was not described in global literature. So truly I was playing blind. First description came in 2014, and now it is well recognized that medium vessel vasculitis can involve the renal vessels and therefore cause renal artery stenosis. And hypertension therefore has been reported as a phenotype. Within weeks or months of this first patient of mine, Dr. Lokeshwar, our beloved Dr. Lokeshwar, ex-president of the IAP, sent me a child who was 4 months old with pure red cell aplasia, which was prednisolone responsive. Every time he tapered prednisolone, the fever would come back. And one day with the fever, he suddenly got a squint and a hemiparesis. Since I had just recently read about DADA2, he mentioned this history to me on the telephone, and I gave him a telephonic diagnosis and told him, sir, this child has DADA2. Next day, the patient was shifted to me, and we found a focal hypodensity in the right putamen and infarct, thereby suggesting a vasculitic illness. MRI showed a lesion in the basal ganglia, and again, the mutation in the CECR1 gene showed DADA2. So now we have found that DADA2, besides medium vessel vasculitis, can also present to the hematologist as a case of pure red cell aplasia with fever, proving thereby that one genetic defect can have multiple phenotypes. And similarly, multiple gene defects can come with the same phenotype. And therefore, genetic testing becomes most important to tease out these patients and give us a final answer. While this child with pure red cell aplasia is in room number 5 in my hospital, In room number 6 comes another child, literally on the same day. And this child, I have been chasing a diagnosis from 2012. Again, with recurrent ischemic strokes, headaches, seizures, squint, MRI brain is showing chronic infarcts. Immediately the penny drops and I say, my goodness me, in 6 weeks, there is a disease which I had never seen before, and I have seen 3 cases in 6 weeks. Again, a mutation in the CACR1 gene. Again, had been labeled earlier, and therefore I clearly told myself what the mind does not know, the eye does not see. Now, my tally of DADA2 actually is not 6, it has now become 7. But do you know the unique feature? 3 out of these patients belong to the Agarwal community. Agarwals in India are known to be endogamous. They may not be consanguineous, but Agarwals prefer marrying within each other. And in press, we have an article now with 28 or 29 cases from India, out of which 7 cases are pediatric, out of which 6 or 5 are mine, which are being reported by Dr. Aman Sharma from Chandigarh. Remember, therefore, when you see a vasculitis in a Agarwal, please think of this talk, adult or pediatric. Move now to another disease, and that is a 5.5-year-old child, non-pruritic rash for 6 months, arthritis for 1 year, recurrent fever with increase in rash for 2.5 years, and interstitial keratitis. And you see this rash, if you see little tangentially, it has a feeling of a sago granules. You do a biopsy of the skin and you find a granuloma over here, a non-caseating granuloma. And this, when you see non-caseating granulomas, everybody obviously thinks about sarcoidosis. And this was amongst the first cases of hereditary sarcoidosis that I picked up. But this child uniquely also had a Takayasu arthritis-like picture, which we therefore reported as a unique phenotype of children with a Takayasu-like presentation of juvenile sarcoidosis. And this is the entire story about this patient who was following up, and now I have a 16-year follow-up in this child. But the most important aspect is, please look at these narrowed vessels in these children. Again, telling you that the moment you see a rather early onset of these unusual diseases, you must think about hereditary autoinflammatory disorders. But this patient has a very unique connect with me, and why I will tell you so is not so much anything else, but this father, when he bought his auto rickshaw, he inscribed my name on the windshield of the auto rickshaw because of possibly the sense of gratitude he felt. And this girl still follows up with me, is doing reasonably well. Unfortunately, her blood vessels of her aorta are continuing to narrow. Remember the triad of arthritis, uveitis, and rash. This is the classic triad for juvenile sarcoidosis. And if you often see that the disease has been going on for long, you may see a deformed pupil like this. So when you have such patients, it becomes very often to shine a torch in their eye because a chronic uveitis may give you a clue. Moving to a third disease, that is chronic infantile neurological, cutaneous, and articular syndrome. These are patients who may often have their onset within days of life. And indeed, this is a child who started running fever from the second day of life. And besides the fever, she would get an urticarial rash like this. And extreme irritability, restriction of movement since infancy, failure to thrive, pallor, adenopathy. And look at her short stature. Her SIB is 7 years old. You know, she is 7 years old, her SIB is 3 years old. Look at the short stature in this. A depressed bridge of nose. And very importantly, these children have significant patellar overgrowth. Very huge patella you will find in them. Some of them may also have a retinal vasculitis. On laboratory, you would find several features, including neurological features, cerebellar or even cerebral atrophy. And then we've also described recently another patient with a novel mutation. Moving to another group of diseases, basically hereditary complement deficiency. I must tell you that lupus is a disease which you normally see beyond 6th or 7th birthday in its acquired form. The moment you see strongly positive ANA in a child below 5 or 6 years of age, think about the hereditary forms of lupus. And the moment you think about the hereditary forms of lupus, hereditary complement deficiency is by far the commonest variety. And I now have 8 patients with hereditary complement deficiency, and the 9th and 10th are actually being worked up at the moment. The issue that we face when we deal with all these type of patients is explaining the diagnosis and prognosis to such patients. The cost of treatment can be quite difficult, and also implied is the fact that treatment is lifelong. Over and above this, there is another major issue, and that is that there are certain drugs which are not even available in our country. And if you try to import them, the cost is such that only somebody like Mukesh Ambani can probably afford that kind of treatment. However, there is a little silver lining that there are some drugs which can help us to at least offer the patient a little better quality of life. And these are available, though some of them are costly. But if we go around with a little bit of a begging bowl, we may be able to offer something to these patients. But I always say, please do not despair. Do not despair for the simple reason that diagnosis always precedes therapy. The various multinational pharmaceutical companies are not yet marketing these drugs here because they feel that they will not be sold. They will not be sold because they feel that these diseases will not be diagnosed. You remember the cost of IVIG so many years ago. Today, the cost of IVIG has come down to some extent. IVIG cost may not reduce because it is a natural product, but many of these are synthetic products. As utility improves, their cost is bound to come down. So friends, just to summarize, I would say that we are only seeing the tip of the iceberg. Hereditary autoinflammatory diseases do exist in our amidst, It is just a matter of our starting to look for them. And when we start looking for them, we are going to find so many that we will say that we have had it. Okay. And as I end this, I might just like to bring to the notice of so many of my friends who might be listening that many of you might be aware that I am running an online program where I teach pediatric rheumatology live online. And the next batch commences on the 12th of August 2020. Anybody who's interested may please email me on rajukubchandani@gmail.com. These are 10 live online weekly interactive sessions of 90 minutes each with adequate reading material and everything and case discussions. So if anybody is interested, please get in touch with me and I shall guide them further. And with this, I come to the end of my talk. Would welcome questions, comments, bouquets, brickbats, everything.
Thank you, Dr. Kubchandani. That was really, really enlightening. To be very honest, I think 70% of what you said has been new to us. And I think it must be for everybody. Of course, the youngsters may be more into it, but I really appreciate the new thoughts. And I think, as you said, I must go back to one of my cases, which may have an autoinflammatory syndrome. I'll have to go back to my files. Over to any questions.
So my story is that as I see 102 people in the audience now, even if each of them jogs their memory and says that, you know, that one child who I saw last year had something like this, right? Then I seriously feel that out of those 100, even if 40 test positive, this talk has achieved its objective. The only reason I wanted to give this talk to Kerala is that I find, and I'm not saying this to flatter anybody, that Kerala is by far amongst the most cerebral audience that I talk with. And I am very sure that people will be stimulated and will follow up on this, and there will be some discussion amongst yourselves to say that, you know, we need to definitely look for this.
That was very nice. Thank you. Geeta, would you like to have any comments? Because you are the rheumatology in person in the medical college.
Good evening, sir.
Good evening.
Excellent talk, sir. As
Geeta is just my friend, so she will never say anything against me.
No, sir. No. No, sir, I'm not flattering. It was an excellent talk and eye-opener, sir, because these things, I think, as you said.
Right, I just wanted to confess that it's not something like you will go tomorrow and see one patient, you know, but it is somewhere at the frontier. Then when you said doyens in pediatrics and gave me such a flattering name, I said I have to do something which is slightly different and not talk about approach to arthritis, which we are now fed up of listening all the time.
Sir, do you see PFA-PA cases, sir? Now,
Yes, definitely. So PFAPA is the commonest autoinflammatory disease which I must tell you about, and that is basically periodic fever, aphthous ulcers, pharyngitis, arthritis. Okay. Now, in this scenario, the patient gets every 4 to 6 weeks, will get fever, will get aphthous ulcers, will get pharyngitis, and will get adenopathy. And it comes with almost like every 4 weeks or every 6 weeks, there will be an episode. And basically, these children need to be treated with a single dose of oral steroid at 1 milligram per kilogram. And when you give this single dose of oral steroid, progressively the gap between the episodes increases and these children grow up, and by somewhere in their teens, they grow out of their illness and live happily ever after.
So no need of any continuous medications, just steroids, that acute stage, that's only what is needed, sir.
So continuous medication, amongst the possible continuous medication that have been tried are cimetidine and colchicine. However, one of the other maneuvers that has been tried in these patients, but is not frequently resorted to because the disease never takes such a severe turn, is a tonsillectomy. Okay. So peculiarly, they have found that tonsillectomy can help these patients. And after tonsillectomy, they live happily ever after.
So when do you, like, when should we think of giving colchicine or cimetidine? Like when the attacks
I'll
of...
tell you, I would have seen about 10 patients with PFAPA. And what I have chosen to do is just give them those periodic steroid therapy only. One child who was 16 or 17 years old and was just not getting well, for him, I straight away did a tonsillectomy and closed the matter. So while I have read about cimetidine, colchicine, I have never used it at all.
Thank you, sir. Then Blow syndrome, sir. You see, you have many Blow syndromes in your...
Yeah, so I have totally 4 children with Blow syndrome, out of which 2 have maintained a follow-up. One was the child with the Takayasu-like arthritis who I told you, and the other child who is now studying in Kota. He's about 24 years old and he is doing that IIT entrance or something. And he was the child whose rash I showed you on the picture with a sago granule rash.
That we have to treat, Alyssa. We have to treat with methotrexate.
To treat these children, Blow syndrome is to be treated with steroids and methotrexate as your first line.
Adalimumab only when the child has uveitis.
Absolutely, but methotrexate can help the uveitis also. And I would keep adalimumab as a third-line drug and perhaps use mycophenolate in between if the child has uveitis.
So no need to start initially, like, when you diagnose one child, we had uveitis at the time of diagnosis. Actually, the genetic test came 6 months later. So child is doing fine on methotrexate. So whether
I don't know, I am a little bit of a cautious, slow prescriber because I have to realize that I am dealing with a disease which is going to last him for a lifetime.
Okay.
And therefore, if I can do the same thing with relatively lower cost, then I play my trump card on the very first game. And then by the end of the 6 months, the patient has run out of money and I have nothing more to offer him. So I like to escalate slowly and progressively.
Thank you very much, sir. So you said you will talk something philosophical.
After the talk.
I was waiting for that.
Before that, Sudha Madam, sir, there are a couple of questions in the chat box. For Sudha Madam, I will read that question.
Sure, sure.
Sir, any drug specific to a particular condition? Please, little more explain about the treatment regime.
So, I very often, many people accuse me of this, and that is that the belief is that please tell us something about treatment also. I just believe that diagnosis precedes treatment, number one. And as of today, the role of the primary care pediatrician should be to suspect these illnesses and to refer them. The kind of drugs that we use for these cases are TNF blockers, etanercept, adalimumab, JAK inhibitors like baricitinib, tofacitinib. mycophenolate in some cases, rituximab in some cases. Now, these are drugs which you need to get some dirt under your nails before you start using them. And therefore, it's best to leave these kind of drugs to people who have experience with them, because adverse effects, monitoring, profiles, etc. are a bit tricky and call for a little bit of experience. And therefore, while it's easy for me to tell you that for DADA 2, please use etanercept. For Blau syndrome, like Geeta and I just discussed that. But I think that it is really very important that possibly somebody was saying to me when they were chatting that there's going to be some other meeting where in November, where they are looking at having some talks which could be of a basic nature. And there one could focus upon those kind of diseases which the primary care pediatrician is empowered to treat and manage, and leave the super specialty diseases to the super specialist. Today you have Suma Balan in your state, you have Geeta Rajan, who's coming up very, very fast in the, arena of pediatric rheumatology. They would be people who would be a little more akin to knowing more about these medicines, which even we today are still learning about.
So the madam, I think Geeta wants to talk.
Yeah, please.
Yeah.
NG Geeta.
Yeah, very good. Yeah, very good evening. So this was a very, what shall I say? The session came exactly at the right time, I feel. And you have really done justice to the very short time you had. And you did say that it's important to look at the vertical pedigree chart. And I would also like to bring to your attention, sir, how important it is to look at the pedigree chart horizontally as well. Like, for example, if you have a child with systemic onset JIA, you of course don't expect the younger sibling to also have systemic onset JIA. So in cases like that, don't you think it is extremely important to consider autoinflammatory syndromes?
I would say it is even more important, and that is why I kept emphasizing on history of consanguinity, because consanguinity makes autosomal recessive disease very, very much more frequent. Diseases like thalassemia, cystic fibrosis, etc., all autosomal recessive disorders. And I cannot but most agree with you. I did mention consanguinity, and while I emphasized the vertical while I was describing one case, I must say that bulk of these diseases, majority are autosomal recessive. And therefore, when you see early age of onset and you see consanguinity and not fitting into any disease which is really described in a perfect way, definitely suspect it. And I therefore said family history too, that lightning never strikes twice at the same place. And if you have two kids with systemic JIA in the same family, make sure that it's indeed systemic JIA, or is it LAC1 deficiency? Okay. And like I was telling you, that many of these hereditary diseases have their acquired counterparts. Systemic JIA, which is an acquired disease, has a hereditary counterpart in the form of something called LAC1 deficiency. And in our series, we have 2 children with LAC1 deficiency.
And
So thank you for pointing that out.
Yeah, and I would also like to just point out to the viewers also that we are running a program, sir. Over the last 3 years, we have a collaborative project with CSIR Institute of Genomics and Integrative Biology, Delhi. And we now have the largest cohort of hyper IgD in India. It is about 13 or 14 cases we have now, and it's being written up. And we, as you rightly said, the more you look, the more you find. And we are finding children with Blau syndrome, TRAPS, FMS, FCAS, and the like. So I'm so very happy that you have made all of us aware. And as you rightly said, the more you look, the more you would find. Thank you.
Any more questions?
Could I please correspond with you also? I would like to know you a
Sure,
little
sir.
more. We
Yes, sir.
unfortunately have not met before, but
Yeah.
RAJU@gmail.com.
Yeah, we did meet in Mumbai, sir.
Into immunology, isn't it, Geeta?
Yeah, we
right.
have a project on primary immune deficiency, sir. And
Right.
as you rightly pointed out, so far the emphasis has been on adaptive immunity and its abnormalities. But now, with the improved awareness that we are also looking at defects in innate immunity. And so, since we have this collaborative project going, it's been a fantastic opportunity for us.
Lovely. Fantastic.
Thank you.
So don't forget, Geeta, keep in touch with Dr. Raju. Right. Any more questions? Okay, then we will wind up. Thank you.
So the madam, sir also promised he want to say something philosophically or something on online. If you wish so.
What we will do is we will keep that for another day.
Yeah, okay, sir.
It was a short 10-minute talk on retirement. But
we will do next time. Okay,
so
sir.
we will keep it for another time.
Yeah.
Unfortunately, at 9:30 p.m. I have another meeting on Zoom, so I just take 20 minutes off. Yeah. Thank you very much.
Thank you so much,
very,
Dr.
very
Raju.
much for a very, very, very patient hearing and a phenomenal eye contact. Thank you.
Thank you, sir. Now over to Madam, wind up here.
Thank you, Dr. Raju. Well appreciated, and kudos to all your cases. Very, very interesting. Thank you from all of us at Calicut.
Now I invite Dr. Nihas, Secretary IAP Kozhikode, for vote of thanks.
Thank you, sir.
Kishore is there.
Kishore is there. Any comment, Kishore? Kishore is
no, sir, I think Raju bhai he's been my mentor. He held my hands when I took steps in pediatric rheumatology when I was working in Thrissur Medical College, which kind of inspired me to continue the training when I came to UK. So it was an absolute pleasure to listen to Raju bhai again. Thank you, sir. Well, autoinflammatory disease is also an area of mine personal interest. So, but obviously the practice would be very different because we have anti-IL-1 available at the drop of the hat. So it makes the life a whole lot easier for us than when compared to what it is like in India at the moment. So I'm so appreciative of, sorry.
Kishore lives in UK, but breathes in Kerala.
Yes. Thank you.
That is his story. You know, and given a chance, he would be on the next Vande Bharat flight. I can tell you.
Thank you for the kind words. Thank you.
Yeah.
Kishore, Nihas.
Yes, sir.
Kishore, CK sir want to say something.
Hello, sir.
Hi.
It's an exciting talk. I heard a medical science.
Sir, please unmute yourself in your device. Yes, now it's okay.
Thank you very much for an excellent talk. I don't say it is rheumatology, in what medical talk of a medical scientist. The perseverance, following up bit by bit and picking up at every stage of the patient's progress and development. Wonderful, emulating for a younger generation like Dr. Geeta and my dear Kishore, and people like that. Wonderful. Thank you very much, sir.
Thank you. Thank you.
Thank you, sir.
Nihas.
Thank you. Thank you. Bye-bye.
Thank you, sir. Thank you, Raju, sir, for coming to us in Calicut and giving this nice and excellent talk and stimulating and taking us through to the rheumatology again. Thank you, sir, for joining us today. Thank you, Sudha, madam, for chairing today's session. I also like to thank our National Vice President, Ananthakesavan, sir, Dr. Ramesh, sir, our President, Narayan, sir, Secretary Bala, sir, for giving all the support to IIP Calicut for doing all the academic activities which we are continuing. Thank you all seniors, CK sir, Shaji sir, and all others who joined us today, and all my friends, colleagues, and teachers who joined us today. Thank you all. We'll be having next session on Friday. Hopefully to meet you all on Friday. Thank you. Good night. Thank you, Raju sir.
Thank you. Bye-bye.
Thank you, sir.